So good afternoon, everyone. Good afternoon, everyone. So I'll be starting with my case of a 13-year-old boy who presented to us with the chief complaint of loss of vision in the left eye. It was sudden in onset, associated with intense pain and redness. He did give a history of trauma with unknown object while passing through a farm. The skin lesion also appeared after the trauma. There was no history of recurrent redness and discharge. Systemic examination was uneventful. On the ocular examination, the right eye was uneventful with the visual acuity of 6.6 and intraocular pressure of 16. The left eye had the visual acuity of hand motions close to face with projection of rays accurate in all the quadrants. There was mild lid edema. The patient was also having photophobia. There was severe conjunctival congestion present with infiltrates which were present in the periphery, and there was intense inflammation, cells were 3+. There was diffuse corneal thinning noted, and we could see the lens was clear. The ultrasound for the posterior segment evaluation was done, which was grossly anechoic. The microbiology workup was also done, and it did not reveal presence of any microbe. The anterior segment optical coherence tomography was done, and it revealed the diffuse corneal thinning with the corneal thickness in the range of 100 microns. Initial diagnosis of viral keratitis, herpes zoster, was made, and based on the periorbital skin lesion and the corneal thinning, the peripheral sterile melt was also there, and patient was started with acyclovir 5 times per day, 800 mg. In view of impending corneal perforation, we planned a therapeutic penetrating keratoplasty as well. Intraoperatively, evaluation was also performed, and we could find out that the bee was stuck in the superotemporal fornix deep. And in order to locate the sting, we also did perform the 360-degree peritomy, and we found the sting, and we went ahead with performing the full thickness penetrating keratoplasty. These are the post-operative day 1 results, and the visual acuity noted was 4/60 with projection of rays accurate in all the quadrants with graft clarity 4+. The graft host junction was well opposed, and the air bubble was present, and lens was clear. Post-operative day 30, patient had visual acuity gain of 660 improving to 680 with graft clarity 4+. So ocular bee stings is a very uncommon trauma, but with variable common presentation. Multiple case reports exist in literature from 1986 till date, and the presentations have a wide range from mild conjunctivitis to severe vision threatening causes like infective keratitis and ophthalmitis. So the mechanism is due to either a penetrating injury due to sting, or because of toxic effect, or because of immunological reaction. And these three also interplay and cause the manifestations. So various manifestations have been reported, ranging from uveitis, cataract, bullous keratopathy, endophthalmitis, glaucoma. Our patient had peripheral corneal melt with a diffuse corneal thinning. The treatment involves the broad spectrum antibiotic administration, and we should focus on administration of a corticosteroid, because the main reason for the manifestations is a heightened inflammatory response in view of venom effect. The removal of stinger is still a matter of debate, and the antihistaminic agents can be prescribed. However, the literature has poor evidence in support of the antihistaminic therapy. Our patient was unique with a peripheral corneal melt, diffuse corneal thinning, and which required full thickness penetrating keratoplasty. Bee sting was also removed. So we believe that whenever it is possible, we should remove this sting, mainly in cases with infective keratitis involving the visual axis, if stinger is located in the superficial cornea, if the response is poor to the conservative therapy. But many authors believe that it can be left intact if the inflammation has subsided. So it has variable presentations. A thorough examination using speculum should be done to rule out embedded sting, and it should be identified and it should be removed as and when possible. Aggressive treatment leads to better results. Thank you.
If I'm not mistaken, you removed the actual bee also.
Yes, sir. We removed the bee and then we located for
When
the
did you find the bee? On table
on
surgery?
table only, on table, because patient was very photophobic. We also applied the speculum, but we could not locate the bee that was stuck quite.
You were unable to evert the lid prior to surgery?
Patient was not actually allowing because of lid edema and because of severe congestion and photophobia.
Yeah.
So we found out the bee during the surgery only.
Yeah. Because I would have even gone ahead and given a facial to allow me to examine to my side. It's like in chemical injuries lime. It's tragic when we find the lime on the table when you take a child. But it's a child, it's a deer. This was an adult with a local block. You could have perhaps found the bee and removed it earlier than you did, because there was a time lapse between your diagnosis or presumptive diagnosis and your therapeutic keratoplasty that you...
It was 8 hours.
Oh,
We saw
same
the
day.
patient in the morning and then we
Okay.
took
So
the
there was
patient
no...
under general anesthesia in the evening.
Okay. Thank you.
Thank you.